Hello everyone, in this lecture I am briefing on some important point in the management part of ectopic pregnancy. So what is ectopic? It is the implantation of zygote somewhere else leaving the normal endometrial cavity. So as we already discussed on its disease portion, so the two parts of that videos are already given in the description box below, so you can watch these all videos before you watch this management, so you can correlate with the disease and management part. So let's see in the management of ectopic pregnancy. Before that also we discussed that the most common site in ectopic is the tube. The tubal pregnancy is the most common site. So let's see how tubal pregnancy could be managed according to their clinical varieties. Okay, so the clinical varieties are also discussed previously. Like one is the acute. So acute term is used when the bleeding is massive and the tube get ruptured. Okay, so when the acute would be there, when there is a ruptured tubal pregnancy. Okay, so when the tube get ruptured, the condition is acute, where the woman shows various symptoms and the woman land up in shock. So how we can manage this condition? Should we go with the medical management? No. In this we don't have any time in hand, so we cannot wait more and directly go with the surgical management. Okay, so not even surgical management alone can revive the woman with this condition. So along with surgical management, we should resuscitate the woman side by side. Resuscitation is equally important because the woman already loses much blood. Okay, so we should perfuse the tissue as well side by side. Okay, so resuscitation with the fluid or with the blood products are equally important along with the surgical management. So resuscitation plus laparotomy. Laparotomy where we incise the abdominal wall. Okay, yes, although laparoscopy is the preferred method in the surgery, but here we don't have time, we can't wait more. So directly incising the abdominal wall and taking out the tube is the only definitive treatment in the acute type of clinical variety. So laparotomy where we incise the abdominal wall and what we do, but actually the definitive surgery is the salpingectomy. Okay, so at the uterotubal junction we just hold the tube, the damaged tube, and incise that tube. We just remove that damaged tube is the only definitive surgery for ruptured type of ectopic pregnancy, or you can say the acute variety where the bleeding is massive, it is uncontrollable and the woman already loses much more blood. Now what you can do in the chronic variety, the other clinical variety. So the chronic means there are repeated episodes of ruptured tubal ectopic pregnancy in that, where sometimes the blood comes out and it will heal automatically. Again there will be a rupture, and so by these all repeated episodes, what happened? The woman is not showing symptoms abruptly. Okay, the symptoms takes time to appear. It means there is a gradual process, but the tube is damaging at many more sites. Okay, so all these blood which leaks through this damaged tube can collect and form the pelvic hematocele. So what you can manage in this chronic is again the same that you can do in acute one, that is you can just do a laparotomy, and when you are doing laparotomy, what you will do, remove all the blood clots or the pelvic hematocele what you have found there, and finally find out the damaged tube and remove that tube. That is salpingectomy. So the salpingectomy means the removal of tube. So yes, the chronic is not that much emergent situation as the acute one, where the woman shows the symptoms abruptly and the woman land up in hemodynamically unstable situation. Yes, the woman is in this situation, but in chronic also the tube is damaged, okay, and it is ruptured at many sites. Yes, although they are healing, but they are forming hematocele there, that we should remove, okay. So in chronic also will perform the same line of management as we do in acute, that is laparotomy, removing all the blood clots, the hematocele, and removing the damaged tube, salpingectomy, okay. Now how we can manage the unruptured type of clinical variety? Unruptured, it means here there is no hurry, because here in this condition the woman is hemodynamically stable. But here the management depends on again the clinical condition of woman. So it depends on the clinical condition of woman. So let's say in early week, suppose if you are checking the serum beta HCG value, on examination if you find serum beta HCG less than 1000 international unit per liter, along with the gestational sac size less than 3 centimeter, and on repeat beta HCG you will find the declining level of serum beta HCG, means the beta HCG is continuously decreasing on repeat examination. If all these criteria are met, then what you can manage here, you can only wait. So the management is expectant management, where you are not giving any intervention. What is expectant management? You are not giving any intervention, means you are not giving any drug to the woman, okay. No intervention is given. Only what you can do is only just repeat this value, just repeat this test for the close monitoring of serum beta HCG, okay. Just close monitoring is enough. So you can even admit the woman in hospital and monitor the serial serum beta HCG level, because if it is continuously declining, it means there is no need to give any medication or any other treatment. Just admit and close monitor her serum beta HCG level, okay. So that's enough, okay. But suppose if the criteria are not met, okay, if these criteria are not met, then what you can do? You can go with the medical management. So what is medical management? Simply administering the drug, and the drug which is commonly used is the methotrexate. So methotrexate is a chemotherapeutic drug that could be given systemically or directly. So methotrexate drug is most commonly used in the medical management, which is a chemotherapeutic drug, as it is usually given in the treatment of cancer patient, and that could be administered through systemic route. It means it can be given by intramuscular route and or directly. It means directly in the gestational sac itself we can administer methotrexate. But the most convenient method is systemic, because it is less costly, less invasive, okay. It is directly is an invasive procedure, but it is not that much invasive. So it is not invasive that much, it is convenient, it is a simple technique. So we'll prefer systemic method to administer, but sometime some technical skills are required for this direct injection. So that depends on person to person, okay. So what is methotrexate? It is actually folic acid antagonist that inhibits the action of folic acid. So it work on directly growing trophoblastic cells to kill them. It will inhibit their activities. So this methotrexate inhibit the folate dependent nucleic acid synthesis. So thereby it kills the trophoblastic cells. Okay. So methotrexate could be given. Before you administer methotrexate, there are certain criteria. If these criteria are met, then only we can administer this drug. So let's see what all criteria are there to administer this drug. So firstly, the value of serum beta HCG should be less than 5000 international unit per liter. On examination, cardiac activity should be absent. Okay, and the size of gestational sac should be less than 4 centimeter. So this is the important criteria. If these all three criteria are met, then only we can go with the medical management. Not even this, along with that, the woman should be hemodynamically stable, because if it is not, then we can go with this management. So woman should be hemodynamically stable. It means the tube should not be ruptured, and she should be counseled very well, because this is not a one-day procedure that today she came and took medicine and now this thing will resolve automatically. No. Here she need to come regularly for follow-up, for taking the drugs in a regular manner, as well as for continuous monitoring of serum beta HCG value as well. So this is very important factor in medical management, that she should be motivated and compliant to this drug therapy. If she is not able to come for regular follow-up and not practicing this all thing, then the medical management won't work properly. So this is another important factor, that she must be counseled and compliant to this medical management. Okay, let's see how we can administer this methotrexate. So here is the route. So suppose if the woman came to you, this is the day 1. On day 1, the methotrexate should be given intramuscularly. Okay, about 50 milligram per meter square body surface area. According to body surface area, we will administer. So ideally this could be the 50 milligram per meter square, and it is to be administered intramuscularly. Now on day 4 to day 7, on day 4 and day 7, we will monitor, we will check the value of serum beta HCG. Okay, if it is declining from the previous reading of day 1, about more than or equal to 15% from the previous reading. Okay, if it is declining from the previous reading and it is continuously declining from day 4 to 7, how much it should be declining? More than or equal to 15%. If it is declining, then we can rely on this medical management, that yes, this treatment is working. Okay, so why on day 4 and day 7 we are checking? Because initially after day 1 to day 4 and 7, what happened? The beta HCG level usually rises and falls. Okay, both will happen. So we'll take this dates, that is day 4 and 7, where then if the medical management is working, then the value will be decreasing. Before that, the value can go up and down. So we cannot rely on that. Okay, because once we give methotrexate, what happened? That kills the trophoblastic cell, and that trophoblast releases more beta HCG in the maternal serum. So there may be a chance that the value can go up. Okay, so that's why we are checking the day 4 and 7 for appropriate results. But suppose if it is not decreasing, it is less than 15% decline in the serum beta HCG level in between the day 4 to day 7, then what we can do next is we can just repeat the same process as what we done here. that is considering the day 7 as a day 1, considering the day 7 as a day 1 and repeat the same dose, repeat the same, okay, same would be repeated here. That is, we are giving methotrexate intramuscularly 50 milligram per meter square body surface area, okay, on day 7. And after that, in same manner, we will check on day 4 and 7 that the serum beta HCG is declining or not. If it is declining more than equal to 15%, then we can assure that yes, now it is working. But suppose if it is not declining, still it is less than 15% decline in serum beta HCG, then what we can do? We just stop this medical management, because now we confirm that it is not working. So we just stop this medical management and go with the surgical management. This is the only choice, that is going with the surgical management. So this is called the single dose regime, because here we are just giving only single dose of methotrexate here. So there are multi-dose regime also, where we can administer methotrexate combined with the leucovorin, that is folinic acid. So combinedly both drugs are given. Folinic acid usually inhibits the toxicity of methotrexate, okay, so we are just combining this folinic acid with the methotrexate if we are giving the multi-dose. But it is researched in many studies that the outcome of both the regime is almost same, whether you prescribe the single dose regime or multi-dose. And on top of that, what is happening, the multi-dose regime is quite costly, it is quite inconvenient, not as simple as the simple dose regime. So because of these all advantages over this multiple dose, most of them, and the commonly preferred method is single dose regime, okay, where only this drug methotrexate is given in a single manner. Now what happens if this medical management fails? So the other method is the surgical method. Surgical management that we can do. Now what all the criteria for the surgical management? Suppose if the medical management fails, okay, you are giving this line of management, and if it fails after giving the second dose of methotrexate itself, the levels are not declining, then you will go with the surgical management. Now if the woman's family is completed, she don't want any child more, her 1 or 2 issues are already there, and she don't want to go with this all medical management which takes time, then also we can go with the surgical management if she prefers. And if the woman is hemodynamically unstable, as I mentioned previously also, that if it is acute type ruptured variety where the hemodynamically unstable condition is there, then also we can go with the surgical management. And if there are the contraindication with the methotrexate, so there are certain contraindication where we cannot give this drug, like if the woman is on breastfed, and if she have any peptic ulcers or any other hepatic, pulmonary or hematological disorders, she is immunodeficient, and if she is consuming more alcohol, so in such women we cannot prescribe methotrexate, and these are the contraindication where we cannot go with the methotrexate. So in these conditions we can go with the surgical management. Now in surgeries there are the two again method. One is laparoscopy and the another one is laparotomy. So laparoscopy is just putting in scope and just do a surgery in a limited area, but here laparotomy is required when the time is not in our hand and we just want an emergent entry in the abdominal wall, then we can go with the laparotomy. But the most preferred method is laparoscopy, where the woman is stable and there is no in hurry. In such situation we can go with the laparoscopy. But these are the just mode of entry in the abdominal wall. But what is the actual surgery through which we can manage this ectopic pregnancy is the other thing. So there are actually two surgeries which could be done nowadays. That is, one is salpingostomy and the other one is salpingectomy. So salpingostomy, ostomy, it means we are creating a stoma. It means in this procedure, when we enter through this either the laparoscopy or laparotomy, what we can do, we just make a linear incision over the conceptus in the tube on the anti-mesenteric border. Okay, on the anti-mesenteric border of the fallopian tube, we just making an incision and remove the conceptus and the product of conception and irrigate. At the same time, irrigation is also must with the saline. So under high pressure we can irrigate, and side by side we can suction all the fluid and the blood which is collected there, and leave the incision as it is. We don't suture that incision. Leave the incision site as it is to repair its own by natural mean, by a secondary intention. So this is the procedure where what we can do in the salpingostomy: making an incision, taking out the conceptus, remove all the fluid and the blood by suction under high pressure irrigation, and leave the incision, and it should be re-epithelialized by natural process. So that is the salpingostomy. So that is to be done in such condition where the woman requires future fertility. If she want any issue in future, then we will perform salpingostomy. Suppose if the collateral tube is damaged, in these conditions we can leave this tube for future fertility. Okay. Previously, salpingostomy could be done where the same procedure is to be performed, but the incision size is sutured by a delayed absorbable suture material. It was researched that it does not have that much benefit over this salpingostomy, so this is not performed nowadays commonly. So the most common preferred technique is the salpingostomy, where the incision is made and it is left open. And the other surgery of choice is salpingectomy. It means simply excising the whole tube and removing out. Okay. So this could be done when the tube is massively damaged. There is no need to preserve the tube anymore, and the woman is also requires permanent sterilization. She don't want any future fertility. In these conditions, we can go with the salpingectomy. Okay, so these are the surgeries, but salpingostomy is the conservative surgery where we are conserving or preserving the tube for future need. So this is how we can manage the tubal ectopic pregnancy, and it depends on the clinical variety, whether it is acute, chronic or unruptured. Thank you.